Okay, I can't hear you at all. What did I do? Hold up. Can you hear me? Oh, Lord Jesus. What did I do? Hold on. I didn't turn you down. I don't hear you at all. Say something. No. No, no. What did I do? Hold on. We were going so well. I was doing so good. Okay, let's see. Let's see. Let me stop this. I don't see anybody in Clubhouse. I don't hear you at all. Maybe I should come. I'll come out and come back in. I don't want to start the room. Okay, whatever. Can you hear me now? I still can't hear you. Hold on. I don't know what I did. I broke it. No. I broke it. Let me see. Okay, wait. Unmute yourself on StreamYard and see if I can hear you.
Can you hear me?
Yes, but I hear you on my computer, not through my system. What did I do? Just that quick. La la la. Wait a minute. Let me see. Hold up. Hold up. Okay, mute yourself, and then just give me some talk so I can see whether or not I can hear you on YouTube. Okay, mute yourself, and then just give me some talk so I can see whether or not I can hear you on. I hear some feedback, but no. Yeah, we can't. Vicky said she could hear me, but we can't hear you. But I don't hear you playing through my, it's not you, it's me. I don't hear you playing through my, oh wait, I see. Well, no, I don't know why I don't hear you. I think, well, now I see the little green lights flashing, but say something. No. I got you all the way up. All the way up. All the way up. Everything is turned up. Oh, wait, hold up. Say something now.
Can you hear me now?
Yes.
Okay.
Okay. I can hear you. Hold up. You hear feedback? Because I probably need to turn you down.
When I talk, I do.
Okay, yeah, I'm gonna have to turn you down.
Yay!
Yay! Okay. And it's messing up my whole tight hour. Okay. or my tight 45 minutes. Okay. All right. I think we're good. I don't want to touch nothing over there. I'm not even looking over there. Good morning, everybody. Welcome. Oh, wait. I got feedback because I'm playing this on. because I wanted to see if I could hear. Hold on. Okay. Now, I think we're good. Yay.
All right.
Look at episode 46, just going awry. Anyway, welcome to the Saturday Morning Tea, where we discuss health information, news, education, certification tips, entrepreneurial strategies. Let's see, what else do we discuss? Anything where the money resides, we discuss it all right here on this channel. I'm Clarice Warner. I'm the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my illustrious co-host, today's episode is sponsored by the Professional Reimbursement Network's free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start, and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right. So if you are interested in getting more information on this free email course on the 5 steps to become a certified marketable medical coder, then feel free to click the link. If you're in Clubhouse, it's at the top of the page. If you are on Facebook, YouTube, and I believe LinkedIn, you can check the description box for the link. So joining me today is my co-host, Mr. Jesse, the registered trademarked the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been an LPN for 29 years. During the pandemic, I created a company called the Coding Nurse LLC, where I help nurses and other healthcare professionals with clinical experience to transition into the world of HIM.
All right. HIM and all the wonderful things that it brings. Yes, I love it. I'm a poet and didn't know it. Look at me. So how's it going? How are you this week?
This week has been good.
Good. Busy over here. Classes started back. Busy over here. But yeah, interesting. One of my classes, I learned something about how insurance started. It was the Baylor experiment where Baylor Hospital actually created its own kind of health plan for its employees. And since they were tied to, I think, the university, all of those folks, they pulled all those folks together to pay money to allow them to have services at their facilities if you were employees. So it was its own kind of little independent. And that was kind of like the birth of insurance. So I learned something like, wow. And then, of course, it has ballooned and now has gone crazy as we know it.
Well, Baylor must be they must have had some pretty innovative people there.
Yes.
I'm hearing a lot of feedback.
Okay.
So I think you might have to mute.
All righty. Okay.
Oh, so Baylor can you hear me?
Mm-hmm.
Okay. So they must have some innovative people because they also have a Baylor program for nurses. They were the first ones to have, you work, I think it was 2 12-hour shifts during the weekend, you got paid for 40 hours. And it used to be called the Baylor program.
All right. Okay. Well, yeah. So I learned that today or this week. Excited about that. Learning all of the things. So today, we're going to get into, before I get into that, if you were on Clubhouse and you want to join in on the conversation, feel free to let us know by raising your hand. And we will add you to the stage so you can join in on the conversation. Of course, those of you on LinkedIn, Facebook, and YouTube, you all know what to do. Just put your information in the chat or in the chat, and then we will definitely add you to the conversation. If you have a specific question, I just ask that you put a Q in front of that so we know it's an actual question, so we can make sure that we get to it and answer it. And don't be shy. You know, your opinion matters here, and it is welcomed here. So yeah, let's get into it. So today we want to talk a little bit about the state of rural health. So for those who are just joining us, let's dig into the state of rural health. So Mr. Jesse, I'll turn it over to you.
Okay. So what made me curious about this topic is effective January 1st, CMS is coming up with a new provider type for rural health. And I thought it was just interesting, so that caused me to do a little deeper dive. So approximately 15% of people in the country live in rural areas. And you might think that's not a lot of people, but that's really 52.5 million people, which is a lot of people. And rural areas don't have access to a lot of basic services. They don't have a lot of access to employment. So therefore, there's not a lot of money. A lot of people in rural areas tend to be poorer than their urban counterparts. So that is in and of itself causes problems in the healthcare system, and it also causes problems with access to healthcare. So they have always had something called a critical access hospital, and critical access hospitals have a criteria, and to be qualified as a critical access hospital, you have to have 25 or fewer inpatient beds. You have to be located more than 35 miles from another hospital. You have to maintain an average length of stay of 96 hours or less, and you have to provide 24/7 emergency care services. So when you have hospitals that have very tight budgets and people with no insurance, that puts a lot of strain on the hospital system. And to that point, a lot of rural hospitals since 2010, 190 rural hospitals have closed. And in 2020 alone, it was 19.
Wow.
So that's taking a lot of access from people. So there's a hospital in Iowa that is closed in I think it's today. They're closing today on October 1st. And then the largest hospital to really have an effect from insurance, especially Medicaid and Medicare, Medicaid, is the Wellstar Hospital in Atlanta. That's the first urban hospital that is closing as a result of finances. And that gets into a whole nother issue, because then you have states who have opted ever since Obamacare has been implemented. You have states who have opted out of the Medicaid expansion to basically give coverage to more people and allow people to pay based on their ability to pay, or they don't have to pay at all, because the money from the expansion would cover their monthly premium. So you have a lot of states, particularly poorer states, have opted out. And I had sent Clarice a couple of articles, because there's a slide, there's a country map, which is really interesting. And when you look at the states that have not adopted the Medicaid expansion, they tend to be some of the poorest states in the union. And it's amazing, and it's just causing, basically what people don't understand is them not expanding is causing all of us to have to pay more for healthcare, because all of those people who are not insured, who still need access to healthcare, who are still sick, it just puts a burden on the federal level, because all the state does is write it off and kick it up to the government. And then we end up coming in to pick up the tab, where if they would offer the Medicaid expansion, you could at least contain some of the costs, so it wouldn't be so runaway. And then getting back to the provider type that's being offered, that's starting in effective January 1st, it's called a excuse me, a rural emergency hospital. And that's different because you don't have to have the burden of having 25 or fewer inpatient beds. You can provide emergency care and outpatient services because emergency is considered outpatient. They can perform emergency observation and outpatient services. So this is the government's way to kind of fill in the gap or provide a stopgap from all of these rural hospitals closing, putting a burden on the few critical care hospitals that are still open and kind of help people through. And it would be amazing if there would be a way because you think, okay, well, now because of COVID, now that everything is telehealth, that should help these rural hospitals and these critical access hospitals. But it really doesn't because those areas tend to also lack basic infrastructure like Wi-Fi, like any kind of like digital connectivity, because these areas are expansive. You can go miles and miles without seeing anybody. Some people own thousands of acres and they live alone, so it's very hard for these wide swaths of regions to be connected digitally. So a lot of people don't have access, which is another barrier to care. Even though now it's nothing for us in urban areas to have a telehealth visit, but in some areas it is virtually impossible. And I think that there's a way, or there should be a way, that these states should be almost forced to do Medicaid expansion. And I think the government needs to step up and bolster the infrastructure because it's too big for the private sector to do it, in my opinion, because they're profit driven. And sometimes the government has to make an investment, and even though it'll pay off years down the line, I just think that that would be the best way to handle it moving forward because these people are not going to move to the urban areas. It's not going to change. So you have to find a way to meet their needs and give them the access that they need to be healthy and successful. That's it.
I agree. I saw this information. I was trying to figure out where did I see this. I don't remember if it came out in the ops proposed rule or in the physician fee schedule. It came out somewhere, the proposal from CMS, and provided some additional information on the new service area, if you will. But you're right, as far as rural health is concerned, it's amazing, and they've been actually closing facilities left and right for a while. And not only are they closing the facilities, but they can't get providers in those rural areas to actually serve and practice. And so it makes it very, very, very difficult and hard for folks to get care, let alone quality care. And to your point about telehealth, oftentimes in rural areas, they don't even have the infrastructure, things that we take for granted, like being able to pick up our phone or turn on our computer and get internet access. Like, we take that for granted. Like, it's like turning on lights. If my lights don't come on, my internet don't come on, we got a problem. Well, they don't even have the infrastructure oftentimes built in those areas to even get that, or the signal is so low that it makes it kind of difficult to even to connect to the internet. So while, you would think the remedy would be, well, just do some telehealth services. It's not that. I know in ops, they were talking in the outpatient prospective payment system in their proposed rule around behavioral health and substance abuse, deploying like vans or having like clinics on mobile clinics and vans or that type of thing, and deploying them actually to those rural areas. And maybe that's, I don't know. It's I don't know, but closing the whole hospitals they've been closing these cause critical access hospitals for a minute because they weren't getting they weren't getting the traction, I think, that they thought they would get. But I thought there was something else about these services or these facilities that piqued my curiosity, and I can't remember what it was. I have to think about that. But go ahead. I'm sorry.
But I think what exacerbated the critical access hospital demise is the opioid crisis, because it wreaked havoc in rural communities. I mean, I had put in the chat that I went to Appalachia a couple years ago to do chart review, and first of all, like, it's very hard. These places are very hard to get to. Like, I had to go to 2 locations. One way, it was an hour and a half from my hotel. One way. And they are these little places that are in the cut, like over the river and through the woods, literally. And it's just so, but when I got there, the majority of the people had some kind of substance abuse issue. I mean, of all ages. I mean, from young to old. And how does a system that doesn't have a lot of resources handle it? And I just think that it just put a burden on it, and it just made them top heavy. And they started bleeding money out of one way without being able to bring in money, because you're also talking about also uninsured people. So it was just the perfect storm of just mess.
Is the facility that's closing in Atlanta, is that in a rural area as well?
No, it's the city.
Wow.
But they have mainly uninsured people, and they're saying that they're not able to keep up because Georgia didn't expand into Medicaid, so these people don't have coverage. And as you know, like, Atlanta is being gentrified left and right.
That's interesting. Are they an independent hospital,
No,
or are they with a system, a large
they're
system?
with the system.
So they're just not going to put the resources into. Wow. Well, that says a lot too. But yeah. Wow.
And it's all political, because when you get into Atlanta proper, their main clientele are people of color. So they don't care. They'll just put the burden on, the other surrounding hospitals, and it'll just be a mess.
Yeah, in the article it says Wellstar declined to comment, but they're pretty much saying that they've acquired this hospital, and once you acquire the hospital, you should. Someone was quoted as saying you should have an obligation to fix it up, and Wellstar has the funds to invest in this hospital, so it's a choice. Wow. But well, there could be some other things behind that too, because it said earlier in the article that there's a lot of condos and modern buildings and all of that kind of surrounding it. So it could have been one of those, let's 3-card Monty, let's shuffle this around, and see what falls out. That's a shame, because unfortunately the people of that community who are still there or who've used that hospital as a resource suffer.
It's gentrification.
And the crazy part, so yeah, well, a few, was it last month? No, a couple months ago, of some friends of ours, and I'm in a book club, and we had our retreat, and we just went up. We didn't go far this time on our retreat. We just went to Columbus, but the one lady was saying, we had an Airbnb, and she said, this area must be part of the gentrification area. And we were like, well, why would you say that? And she was like, look at the numbers. So she looks at the font of the address, the house numbers, and it's a specific font. And once she said it, every time we rolled past somewhere, we were like, those are the gentrification numbers. This is where it's happening in this particular community. And so I'm tickled by you saying that, but it's not funny at all. But I never thought about as you think about housing and that, but now you're talking about medical services and hospital services being part of this whole gentrification piece. So that's really, really interesting that that they would kind of pull that trigger there. I mean, where was the folks in city government who was policing this, who was watching this to see what would happen, or where would these people get their care? Well, I guess it's the same thing with them moving them somewhere else to live. So I guess it's just moving them into another hospital system or hospital facility to get their care. But that's deep.
Well, what's interesting is that Georgia politically it's just very contentious there. And even though Atlanta itself seems to be Democratic, a lot of these decisions for hospital acquisitions are made at the state level.
Mm-hmm.
And the state government is very, very, very Republican. So I don't really think that their main concern is, servicing, people of color in, traditional Atlanta neighborhoods. And this is not necessarily new, because in Boston it's the same thing.
Mm-hmm.
They have some very, very well-known hospitals in Boston in Black neighborhoods, and Black people can't even go there, or they go there and get treated like crap.
This is a shame. I mean, so take this, and I also read an article this week about, and this is not just necessarily on gentrification, but there are other, to your point, there are other hospitals that are slated potentially for closure, and they're looking to say that in 2022 going into 2023, the financial hit that some of these facilities have received is devastating. And so a lot of these facilities are actually, I don't know, they're restructuring. A lot of folks are scrambling right now with the restructuring of facilities. But my thing is, I know COVID plays a part. I know the public health emergency plays a huge part, but I think what it did was exacerbated it. So I think it was already happening. Things were already moving in that direction. I think she said, I'm in Michigan and I see it too. Yeah, it's everywhere. I think it was already happening, because if 10 years ago, the talk had always been about moving care from inpatient to outpatient. It's been, and folks have been slowly, I guess, holding on, thinking, it wasn't going to happen. I don't know. But, you only the acutely ill are to be in a hospital facility and to be treated in a hospital facility. Everything else was treated on an outpatient basis. Or now they're even doing acute care at home. I just saw an article about acute care at home, where they're actually deploying people to care for folks in their home. Acute care, not just like rehab, not just dealing with chronic condition, but acute care. A doctor, the house calls are coming back, and the people who assist in that are following suit. And I'm like, wow, I just imagine deploying like doctors and nurses and techs and all these folks in your home just to care for you. I just, it's wild. But that whole thing, because they can't afford the facility. Look at business as a whole. So you have corporations, and not necessarily just healthcare, but you have corporations who have buildings that don't have bodies in them anymore. They don't have that industry is, so they don't even, they're downsizing those facilities. We can't pay that rent because we don't have people, we don't have the staff, we don't have it makes no sense. It makes no business sense. And so I think I think it's going to get worse before it actually gets better. I don't know. I just, it's sad, but ultimately care is going to hurt everybody, but I think it's going to really, really hurt those in the socioeconomic lower end of the spectrum, those who are Black and brown. Just it's going to hurt even more. And once we get out of, oh, my professor in the class about insurance, because we talk about healthcare, is healthcare and IT and how all of that works together. But she deals with eligibility, and she says, imagine that you have a lot of these people who, because of the pandemic, have been able to receive healthcare services. They've been able to get on Medicaid or receive some sort of Medicaid services without going through any eligibility. And you know that that's a huge matrix of it in and of itself that you have to go through for eligibility purposes. Well, when the public health emergency goes away, the things that they have allowed as far as, well, come on in, we'll take care of it, we'll do whatever, that goes away. And that old process of, well, we have to make sure that, the gap is going to get closed. It's going to close. And so those folks who fall outside of the parameters are going to get caught. And to your point, if Medicare or Medicaid expansion didn't happen, it's going to be way more people who are going to be uninsured, and way more people who may have chronic conditions, may have conditions that they have now received because of COVID, or, maybe they, have some longstanding issues related to it, or, just current exacerbation of some of the chronic things that they have, who really, really need those services and will not be able to get them, or get them, not necessarily get the quality because of the insurance. And I mean, if you don't have a charity hospital nearby, if you, like you said, New York with their public hospital, if you don't have those types of resources nearby, it's detrimental. It's sad. It's a sad state of affairs.
But eligibility, I think that's really only an issue for places that did not accept Medicare expansion. Because here in Pennsylvania, I can speak for Pennsylvania. You're not just walking in getting. They're going to, if you get Medicaid, you would qualify for Medicaid, and they refer you to the marketplace, and it's based off of income. If you have a certain amount of income, then you go to the marketplace. If you have under a certain amount, then you get on Medicaid. Because when I was on unemployment, I had insurance through the marketplace. Then when the pandemic started and people's unemployment stopped for weeks, like mine stopped for like 2 months, I was then eligible for Medicaid because I had no income. Then once I started getting money again, then I went back to the marketplace. So I just think that it all comes back to, I don't know, well, clearly universal health care in this instance still is not the answer, because these people in rural places still don't have access. But I want to mention one more thing about rural access. What is interesting is who owns land, because now Bill Gates is the largest private landowner in the country. Mm-hmm. And we know he's not buying up urban areas. So I'm thinking, what happens if he bought a whole lot of land in a state that has not accepted Medicaid expansion? And let's say for whatever reason, politically, he doesn't want it. And you can have an undue influence because he owns a lot of land. So that means he has a lot of say politically. And I think about Dave Chappelle had caught a lot of flack earlier. It was either early this year or late last year. Somewhere in Ohio, wherever he lives, they were trying to build this development that was going to have affordable housing. And he went to the board meeting and told them basically if they went forward with this, he was going to sell his property and move. He was going to move out the state or something. So it got blocked. So it's that kind of influence that is kind of also going on the back end that's not too copacetic.
Yeah, he's in Yellow Springs, Ohio, which isn't too far from us. But he there was more to that story as well. um, um, yeah, there's more to that story, but which I won't even get into all of that. But yeah, there's more to that story.
But it always is when it's poor people. It always is when it's poor people because in New York City it's the same thing. Like in order to get these people want government money to build these luxury properties, but all they see is you have to have a certain amount of affordable and low income housing. Not all of it, not even the overwhelming majority, just a percentage. And why that is so hard, if it's that hard, then take all of your private money and build it. Don't take my tax money and get tax abatement, and then you want to discriminate. You can't do that.
You're right. You're absolutely correct. He Yeah, you're absolutely correct. You're absolutely correct. Oh, so to your point about the eligibility, it's in so the threshold, the cutoff is different in different because it's state specific. And so everybody's threshold, I think for the public health emergency, I think there was a, a give a standardized threshold. But when the emergency goes away, everybody goes back to what their state was. So I know in Texas, their threshold is very high. It's a lower threshold, but it's high compared to others. So somebody's may be 400% over the federal poverty line versus 100%, and Texas may be at that 100%. So you fall out because you don't meet that threshold, and so that's where.
Right, but Texas also has rejected Medicaid.
Correct. And so you're going to see a lot of that happening with those areas. Yeah, that's right. It's the gatekeepers. It is the gatekeepers. Um, so that's interesting. That's real interesting and sad.
And truthfully, all of this, the reason why all this is interesting to me and to all of us in HIM is because there's potentially a lot of opportunity once all this gets sorted out. Because what I'm thinking is when you think about the connectivity issue, imagine if during this, because I don't know what was in the infrastructure bill, but let's just say that, President Biden had put in billions of dollars for fiber optics to be laid through, 20% of rural America.
Mm-hmm.
That would open up so many opportunities. Just think about all of the nurse practitioners who could come online and provide telehealth. And then they could coordinate with, local services if somebody needed something, right there, like physically. There would be a whole lot more coordination of care. There'd be a lot more visits. It'd be a lot more, substance abuse. They could do group counseling over the internet. They could do a whole lot of things that they can't do currently. It would be a lot of opportunity. And once again, for people in HIM coders and auditors and all that, this is just a lollapalooza of opportunity for us. So I just think that eventually it'll get together and there'll be a lot of opportunity for employment.
I agree. And I think, again, going back to the whole the physicians versus nurse practitioners, if you don't have the physicians wanting to serve or practice in those areas, then again, here's another reason to allow the nurse practitioners to have their own autonomy, to be able to um, set up shop, to be able to create their own clinics, create their own practices, even to the point of, like I mentioned, with substance abuse, having those mobile vans, they could have their own mobile clinic and, go and service those people without having the physician oversight or the physician supervision. Let the nurse practitioners do what they need to do in order to serve those areas, particularly in our Black and brown areas where, we go make sure we take care of us. And if you allow us to do that, then, it's no harm, no foul, right? You don't want to do it. So why not let us do it? You know what I'm saying? So I just, it's crazy. It's crazy.
And just like Sequisa had mentioned in the chat, full practice authority.
Yes.
There you go.
Yes. Good morning, Sequisa. Exactly. I don't understand, why they won't just, I mean, just let it go. Just let that fight go. It's okay. But I'm so glad to see that other states are coming aboard, and I'm waiting for them big ones. I'm waiting for those big ones, because once those big ones hit, it's downhill from there. So I'm excited that they got the 25 right now. I think it's 25 we mentioned before.
Well, I think we need one. We need one more because we already got New York is huge.
Right, New York is huge.
We just need either California, Texas, or Florida, and it's a wrap.
Yep, because then everybody else gonna follow suit. So, I know they were doing a lot of work in the Carolinas. Unfortunately, I don't know. Hearts, prayers to anybody who's been affected or impacted by Ian and Fiona and every hurricane that's coming down the pike. It's bananas. But I know I think it was North Carolina was really, really, really digging their heels, and in this potential political climate, was trying to get some things overturned in their state, to assist nurse practitioners to be able to practice independently. So, yeah, it's crazy. I just let them just let it go. Let it go. You don't want to do it. Let it go.
It's gatekeeping. That's the word of the year.
Yes, look, y'all gonna make me look for my little my thing, the gatekeeper. It's crazy.
I can't hear you.
My bad. It's crazy. Okay. It's crazy. Yeah. So
9:42.
Okay, let's see. I got a heart out. Let's see. I'm sorry, LaShanta. Prayers to you. She said she's in Florida. It was brutal. I've seen, just seen the pictures. It's like, oh my God. Definitely prayers going out to you guys. And somebody, oh my God, I was on Twitter looking at something, and they were talking about why people didn't evacuate and whatever. And it immediately, I went back to our discussion on those who are disabled and not having an evacuation plan for them. Like, do y'all, people don't think about, they think about able-bodied people being able to just pack up and be like, okay, whatever. Well, no, people who rely on and are, they need people to survive. They need their care. They need, they got medication or devices or appliances or whatever. Those things you can't just readily pack those things up and go, or they just really need to, in all these areas, especially any areas around, and unfortunately, and I think we talked about that, where the areas they don't, right around the coastlines, they really don't have the appropriate protocols in place for disabled people, and so they get caught and they get stuck, and it's like something. I mean, somebody was just going off like, this wouldn't have to happen, and we wouldn't have to deploy the first responders, and now their life on the line because the people chose not to go. And it was a whole big, Twitter can get real nasty, so I was like, ooh, let me just swipe because it was a mess. Goodness.
Well, that's always a huge debate every time there's a natural disaster, because there are some people who they're able-bodied and just want to be insolent, but then there's a lot of people who really can't. And I don't know where it was, but I saw a picture of an older man. He had lost power, and he was at some establishment using a nebulizer because he had no power. That's
yeah. And then I think there was, well, at least, was it last night, 2 million people without power? It's a lot of people without power right now. Yeah, that's crazy. That's crazy. And I'm nervous because I think the last time when I don't remember which one it was that hit North Carolina, and then the winds just came straight up through Ohio. It came straight up through us and knocked all our power out. We were out of power for a couple of weeks. So it's like, whoo, this is crazy. Global warming, climate change. It's a whole other conversation. Yeah. It's a whole other conversation. Okay, well, we have to run today. My MCDA, the Metro Cincinnati Dance Association conference is here, and I got to go to the conference. So this week a conference. Next week, if you're part of a HEMA and you're coming to Columbus, come look me up. I'll be in Columbus. So feel free. So that's why we won't have a session next week because I'll be in Columbus. I may go live or do something and show folks like, look at all the people, look what's going on. We may do something like that. Yeah, I got to reach out to you too, because I'm thinking about the end of the month doing our Philly thing. So we may come up to Philly at the end of the month. I'm trying to get it in because we close to it. I wanted the 50th episode. I don't know if we're gonna make that. So it might be close to the 50th, maybe 51st, 52nd, something.
You know, and it's so funny because I was thinking, I didn't want to say anything. I was thinking that I might just come to you. It'd just be easier.
Ah!
You have, but I got to see how the whole job thing works. So we'll talk about it.
Okay, definitely we'll chit chat this week. So we're gonna have a meetup. We're gonna have a mashup where we're actually face to face and actually provide some sort of opportunity that if anybody wants to come and join us, that they can do that as well. So yeah, we'll do that. All right. So this has been a great session. At least I thought so. Mr. Jesse, do you have any closing thoughts?
No. We covered a lot of territory, and rural health is very, very, it's not talked about enough in urban areas, and there's a lot of opportunity for everybody in healthcare.
It is. And once again, this is part of the opportunity to advocate for the nurse practitioners, advocate for rural health in general. Just, you see that there is a need. There are several organizations that are fighting for that. So, connect, show your voice, be part of the solution, not part of the problem. So again, thank you all for joining the Saturday morning tea. Was the tea spilled today? I believe Mr. Jesse spilled a lot of tea today. If this information was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the Professional Reimbursement Network's channel. You can also check out the Coding Nurse channel on YouTube and subscribe there as well. Make sure you hit that notification bell so you'll be notified of our weekly show. I call it a show. All right. We've been here long enough. It's a show. Last but not least, to my Clubhouse folks, make sure you click on the greenhouse to join in on our club. You will also get notified of our live broadcast. So this has been a great session. I know I learned some things, and hopefully you've learned some things as well. Thank you all again for joining us. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care.